Welcome, everybody. My name is Denise Campbell-Chair. I'm the Associate Dean for the Office of Lifelong Learning Physician Learning Program. And it's our absolute pleasure to host Dr. Quentin Durand-Moreau today, who will be speaking to us about debunking myths around work-related mental health. We acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So just in terms of introductions, Quentin. So Dr. Quentin Durand-Moreau is an assistant professor in the Division of Preventive Medicine and the director of postgraduate occupational medicine programs here at the University of Alberta. He is the medical education representative of the Occupational Medicine Specialists of Canada. Clinically, his work is in mental health assessments in France initially, and he now works at the K Edmonton Clinic as an occupational medicine specialist at the Occupational and Environmental Medicine Clinic. So he's qualified in occupational medicine in Angers in France in 2013, and he holds degrees in industrial toxicology and addiction medicine. He's also been trained in work psychology at the Conservatoire National des Arts et Métiers in Paris. He is currently co-chair of the International Commission on Occupational Health Scientific Committee on Work, Organizational and Psychosocial Factors, and he's a member of the Council of Scientific Affairs of the American College of Occupational and Environmental Medicine. He participated in the development of the French National Health Authority guidelines on burnout and has been consulted at the French National Assembly on work-related mental health topics. So it's our absolute pleasure to hear about debunking myths, and I'm going to turn it over to you, Quentin.
Thank you very much, Denise, for this very kind introduction, and thank you all for attending this webinar. I'm really happy to share with you some of my thoughts around a couple of ideas and common statements that are usually said with regards to mental health at the workplace. I'm trying to fix the issues of sharing my screen and moving my screen. If you would like to bear with me a second. Here we go. Sorry for that. I thought I was ready and I'm not. Oh, there we go. Here we are, and it should work now. So you should see my slides. Can I have a thumbs up?
Yeah, we can see it, Quentin. Yeah.
Okay, sounds good. Thank you. So I would like to start with my disclosures as usual. I don't have a lot of disclosures to report, but I would like just to point out that I do hold some grants as a principal investigator from the Workers' Compensation Board of Alberta. And this grant is related to some topics that I'm going to discuss in this presentation with regards to mindfulness and the use of mindfulness at the workplace. But this being said, I'm not working with WCB Alberta, and I am not the voice of WCB Alberta at all. So during this presentation, I'd like to go through 5 questions that are related to what I call some myth, some legends with regards to work-related mental health. And you're going to see some polls appearing with all of those questions. So you're going to give your opinion on each one of this. So here on your screen, you have the first one. Are psychosocial risks a new trend? And I guess you can start and vote. And I'm going to open that for a couple of minutes, a couple of seconds. So I see. Okay, nearly everyone has voted. Okay, I'm going to share results. So we have quite an interesting distribution of the answers. And not one answer is taking the majority, but the highest number of respondents said not at all new, and that's the correct answer. The notion of psychosocial risk is absolutely not new, and I'm going to share with you a couple of historical events and historical information that is going to provide you with some background and knowledge about how not new it is. And I'm going to go fairly early in history. We are 1,700 years ago, and at that time, Evagrius Ponticus has conceptualized something that he called acedia. And acedia has been described as an unnatural weakness of the soul, which does not resist to temptations. And he said that, or he presumably said, I'm a little bit cautious with some texts that are so old, but he said that monks suffering from acedia would be nonchalant with praying. Sometimes they would not pray at all. This is an interesting description that has been reported in a book from a work sociologist, Marc Loriol. This book has been published more than 20 years ago now. It was his PhD dissertation in work sociology. And in his book, he provided an interesting historical perspective on all of the concepts that are related to burnout, basically, like being overwhelmed, neurasthenia, fatigue, all of this wording about work-related mental health that has existed for years. And in his historical research, the inception of all of this was thought, to his point of view, to be Evagrius Ponticus back in 345, 399, which is quite interesting. And here, with the concept of acedia, you have the description of the effect on work issues, on work outcomes of a mental condition. With acedia, the monk is not doing their job because this is their job to do the prayers, and they are not doing this because they experience acedia, which is quite an interesting description of the links between mental health and work outcomes back in the days. And what's even more interesting with regards to acedia is that not all monks would experience the same levels of acedia. And it has been noted that cenobiacs, which are monks that are living in communities, were experiencing lower levels of acedia. So it could be very well the first description of what we call now the social support. And social support is now included in commonly used job stress model, like the model from Robert Karasek, for instance, includes 3 dimensions: job demands, job control, and social support from the hierarchy, from the colleagues. So this is quite interesting that already at that time, we noted that having colleagues around you, having people around you is going to give you some better outcomes in terms of mental health. I'm going to jump to closer to us now, just 1 century ago. At that time, we had quite a famous philosopher in France, Simone Weil, and you can see her picture on your screen. Simone Weil was an interesting philosopher because she was living as an academic and a teacher, and at some point she felt an urgent need of experiencing the working conditions. So at that point in her life, she resigned from the academic life and teaching and whatnot, and decided voluntarily to go and work in factories. And she did that in several factories, and she kept a diary. Every day, she was writing down on the notebook whatever she's been doing at the workplace, whatever relationships she had with her supervisors and colleagues, and how she felt. So this has been published in French. It's called La Condition Ouvrière, and I don't think that I've been able to find any translation in English. So it's going to be my translation on the screen. So the short text that we are going to go through right now has been written in 1934. At that time, Simone Weil has just started to work in a new factory. She's been working in a factory just before, and it is day 1 on another factory she's been working on. And in this factory, they were building the Renault car. So it's quite a famous French brand of cars, already existing back in the days. And the factory was at that time located in the western part of Paris, on the middle of an island located in the river La Seine. So there was an island in the river where the factory was located. So really to get access to the factory, you needed to cross back and forth the river. And this is the end of her first day there. It went very, very bad. And this is what she's wrote at the end of the day. Despite my exhaustion, I need fresh air so much that I walk back to the Seine. Here, I sit by the river on a rock, emotionally exhausted because of this powerless rage, literally burned out. In the case I would be condemned to live this life forever, I wonder whether I would be able to cross the Seine without throwing myself in. Here we have one really, really clear description of work-related societal thoughts. Clearly, she is thinking about committing suicide at that point. She didn't die of suicide because we have additional pages in our notebook and diary. But still, we have this. It is common thoughts to consider that back in the days, at the end of the 19th century, early 20th century, to think that work-related risks were physical, only physical. People at that time were working in dangerous industries, so the occupational risks were to lose an arm, to lose a hand, fingers, and whatnot. So at that time, it is common knowledge to think that because they would experience so dangerous physical risks, they wouldn't even think about having psychosocial risk. It was not even existing. That's wrong. Both coexisted at that point. There used to be psychosocial risk already back at that time, but the interest was, of course, more on risks that were more important and providing an immediate threat to the lives and integrity of the workers. But already at that time, there were already descriptions of work-related mental issues. And the last example I'm going to take is one of this book, that is a book written by former professors of the Conservatoire National des Arts et Métiers, where I got myself my training way after 1961. This book has been written in 1961. And it's called Le Surmenage des Dirigeants, which I can translate by overwhelmed managers, by two professors in this institution, René Bise and Pierre Gauguelin. And the basis of this book, written in 1961, was to provide some tips, some advice to CEOs, to top managers, to people who are in leadership positions in factories and experiencing stress at the workplace. So back in 1960, in the 60s, it was already a thing good enough to provide a full book on that issue. And this book is really about providing self-education tips, how to cope with work-related stress, including already methods inspired by yogi and Buddhist tradition. Causes of stress, interestingly, include abusive fiscal pressure. They were getting into a little bit of politics in here. Unskilled collaborators, so you are stressed because your collaborators are unskilled. And I didn't dare writing down that on the slide, women, because of course, at that time, the vision of the leader in a company was obviously a male, and males were bothered by women when they got back home, who were discussing chit-chat, useless things about kids and, you know, problems with washing machine and things that are putting additional burden on those so tired, so stressed CEOs and directors. So this was really the state of mind that is described in this book by academics. Really, it was two academics writing this. And what I like most in this book is really the end of it, where you get tables of here spa centers, where you have a list of all of the spa centers with where they are located, the best composition of the water, whether it's a little bit of more sodium in the water, a little bit of more chloride in the water, and how well it fits with the conditions you're experiencing, whether you suffer from obesity, diabetes, gout, and whatnot, and how good it could be for managing your work-related stress. The thing is that nowhere in this book there are any insight, any information with regards to working conditions, but we are talking about the managers who are responsible for setting up working conditions. We are talking about the top management, the ones who have the power to decide about reducing the workload, hiring better staff, hiring more staff, things like this. And it's not even discussed. Everything is focused at the individual level. And it is quite something to see that still now with people involved in well-being in companies, that this may be the natural trend we have to focus on individual factors. It's always easier to focus on individual factor rather than thinking that there are collective factors or organizational factors, because we cannot tend to think that it's impossible to change. Organizations are impossible to change. So we're transferring all of the responsibility on the workers, and they are asked to do the training and be better workers with such advice. So this is the end of this first question, and I'm going to move without further ado to the next one. Is working too much, more precisely, too many hours per week, increasing your risk of depression? And these little breaks are an opportunity for me to take a sip of water. And I see the answers that are pretty much interesting, and you're very quick with responding. Almost everyone is already responding. Interesting results. Okay, I'm going to share the results. Here you see the answer. So 90% of the respondents respond yes, working too many hours increase the risk of depression, and 10% no. The minority is right. There is no official link between the number of hours and the risk of depression. And to expand a little bit on that, I'm going to report a research, a huge project that has been conducted with the WHO and ILO. So many of you, I suspect that most of you come from the field of health. So you know about WHO, World Health Organization, but maybe you're a little bit less familiar with ILO, International Labor Organization. This is same, an equivalent of WHO, an international organization that deals with regulations, conventions, and recommendations with regards to labor laws, work laws, and set up standards for working relations around the world. This project I'm talking about was launched at the initiative of both agencies, because it was about occupational health, and it crosses labor and health. And there was a launch of this joint methodology for estimating work-related burden of disease and injury. It's a very, very long process and technical, but within this big piece, there were 9 systematic reviews that have been conducted with the same methodology. All of these systematic reviews have been published in an open access journal, Environment International. So if you want to look at those systematic reviews, it's easy to get done, some access to that. And within this systematic reviews, there were pairs of exposures and outcomes that have been looked at. So for example, there was one systematic review on the effect of exposure to noise on any health effects, exposure to solar radiation on skin cancer. And among all of this, there was a couple of systematic reviews who looked into the exposure to long working hours and a bunch of different outcomes, including depression. And I've been involved in the group who was conducting this systematic review on the link between long working hours and depression. So when we do a systematic review, we do have some criteria, which are called the PICO criteria, or in here, because we are looking into exposure, PICO criteria. So we define the population, workers, more than 15 years in both the formal or informal economy. So it's important because you have to have in mind that it's an international review. So we're looking into different countries. So the results should be meaningful for all of the workers around the world. And in some countries, most of the workforce is employed in the informal sector. So informal means that there is no formalization of the working relation. There is no minimal wage. There is no protection. This is just work that occurs like this without any framework to secure the nature of the subordination relationship. In some countries, like in India, for instance, close to 90% of the workforce is in the informal sector. In developed countries, this proportion is lower, but still there is an increase in the informal economy, and in Canada, for instance, would be reflected in the increased use of the gig economy, such as Uber, Skip the Dishes, and all of these things are considered to be part of the informal economy. So we have to look at those workers, whether or not they were in the formal or informal economy. The exposure was considered to be long working hours, and the definition of long working hours was more than 40 hours per week. And yes, I can hear you laugh behind your screens, each one of you, 40 hours per week, I'm doing way more than that, and I believe you. I really believe that most of the healthcare workers or professionals involved in this webinar may work way more than 40 hours per week. But this was the threshold that has been decided, saying with consideration that it was an international study, and also with the idea that ILO was part of it. You know, the guys setting up the standards for advancing, you know, social conditions at the workplace. So if you were to set up that standard working hours were up to 50 hours per week, it would be as if they were diminishing or, you know, reducing the importance of complying with the standards, which should be anywhere between 35 and 40 hours per week. So this is why this threshold has been defined, and also with respects to the existing literature available on this topic. But really, long working hours are considered to be more than 40 hours per week, but I really understand that you may think that it wouldn't be really long for you compared to standard working hours. And we had looked to different outcomes with regards to depressive disorders, prevalence, incidence, and mortality. And long story short, we didn't find any difference in terms of any of those outcome. Here you can see forest plots. I'm not sure that everyone knows how to read those figures, but results for each subgroup of working hours are displayed in here. So we made different analysis, 41 to 48 hours per week compared to standard hours, then 49 to 54 compared to standard hours, and more than 55 hours per week compared to standard hours. And at the end, inadequate evidence of harmfulness of long working hours for depression, prevalence, incidence, and mortality in more than 1,100 participants. So what can we say based on that? Is it really that there is no link between working hours and mental health? Well, it's maybe more complicated than that. And really a systematic review on this question with this criteria, with this PICO criteria may not be the best way to address that question, because the relation between working hours and depression may be circular and in both directions. So if you take the depression, you can have a worker experiencing depression, and this worker may have a decreased productivity, less efficient. He is like concerned with so many concerns. He is thinking about, they are thinking about a lot of different things, and they are not focused on their task. They have decreased productivity and they need to catch up. So they are doing additional hours. They would work longer. Or workers with depression are not as motivated as they used to be. Maybe they were doing additional hours and they stop doing this. They just do the bare minimum. So they won't do additional hours. So it may have an effect in both directions. And with regards to long working hours, it may be related to an increased workload. People are asked to do more and more work, so they are working more, which provides them with additional stress and then depression because of, at the beginning, an increased workload. But it may be also that you can get very motivated workers with increased motivation and willing to stay after hours and do more. It exists. So it's very difficult to have a single, explanation between time and the health outcome, because it really depends on the nature, on the details, on the nature of the relationship between the worker and their work. As an aside, it's really important to have in mind that this very methodology, this big report, including a systematic review and additional estimations on the link between long working hours and cardiovascular diseases, including myocardial infarctions and stroke. And here the link was positive. It's been shown with this methodology that working more than 55 hours per week increases the risk of cardiovascular diseases. And it is estimated, based on this work, in year 2016, that 750,000 workers have died because of long working hours and cardiovascular diseases, which is huge. I think that nowadays, long working hours should be considered as a cardiovascular risk factor, seriously. But no evidence like this in the field of mental health. I'm moving to the next question. Are work-related mental condition compensable by a workers' compensation board? I see the number of answers going up, and I appreciate your participation. And it's really exciting for me to see, the bar moving. So here, the poll is over, and here. So we have 3/4 and 1/4 of the respondent. And here in this question, it's the majority who is right. Yes, work-related conditions can be compensated by a workers' compensation board. So I'm going to go into a couple of information with regards to that, because I think that it's important to have in mind that reportings need to be done whether the condition is physical or a mental health condition. You may or you may not know that workers' compensation jurisdiction and laws are at each province and territorial level. But there are common principles that are across all of the workers' compensation boards in Canada that are called the merited principles. I'm not going to go into details, but I would like to share some key information for you to be able to deal with this topic in your practice. So have in mind that most employed workers are covered by WCB, but not all. It can get complicated. If I were to go in the teachers, for instance, coverage by WCB or not would depend on the topic the teachers are teaching. So it may be a little bit tricky, but as a simple fact, keep in mind that your first, stakeholder involved in the compensation for employed workers is WCB. If it's not, there would be like some information, the request would be redirected. There would be some rerouting of the request to the appropriate provider. The Workers' Compensation Board has been built on what we call an historic compromise between employers and workers and their representative. Remember back in the days when we were talking about Simone Weil, think about this industrial environment where the industry was so dangerous. It was very, very full of hazards, and people at that time may lose a limb, lose a finger, or lose their lives. Even though there was some work-related mental disorders at that time, there was a significant number of injuries, and very serious injuries at that time. And in the early 20th centuries, all across the world, workers started to sue their employers because they were injured because of unsafe conditions and whatnot. And years after years, employers started to lose their trials. They were losing, like workers were winning those trials, and employers were like, "Oh, we need to work on a compromise, and we may need to accept that work is dangerous." So that's why employers were part of this historic compromise. So there was some negotiation between employers and workers. On the one hand, employers agreed on funding an independent workers' compensation system still in place here in Alberta, Workers' Compensation Board of Alberta. An employer would pay premiums to the system for an independent management of claims. And on the other hand, injured workers surrender their right to sue their employer. So there is no point in having a lawyer or going on court. It is an exclusive jurisdiction. Anything that pertains to an occupational injury or work-related disease or whatever that is the field of WCB should stay in WCB. This is an exclusive jurisdiction. There are ways to appeal. If the first decision you're not agreeing with, you can appeal. There is a process. There are different steps of appeals. It is possible, and it's notified in writing to the claimant. It's WCB that does the adjudication. So it's really important not to act as a WCB adjudicator when you are in your office with a worker, a patient, or whoever, if you're not sure. There are this like situations where there is no point in sending off a claim because obviously it's not work related. But you know, there is all of this gray zone where, yeah, there are work-related factors, but there are also some personal factors. If you think that there are some professional factors, if you think that work may have played a significant role in this, well, send off to WCB. They are going to do the adjudication. They are going to review the case. They are going to make an investigation and make a decision. But do not refrain from sending off the claim because you don't know, maybe they would accept something you think that wouldn't be compensated. It's best to report a little bit more than less. And also a thing that often arises in my experience when we start about talking about WCB with worker, they say, oh, but I want to keep my job. I'm still fit for the work. I don't want to lose my job. So you need to reassure them. These are separate processes. Work-relatedness and fitness for work are different. You can keep your job if it's safe, even with a work-related disease. So you need to reassure the patients and the worker with regards to that. So these are general principles applicable to any disease presented by a claimant. If I go into a little bit of specifics with regards to mental health. With regards to mental health, there are two things. First, a presumptive coverage when workers meet some criteria, and there is the case where the presumptive coverage wouldn't apply. So for some diseases, dates of diagnosis in professions, there is an agreement that these diseases, if they fulfill some administrative criteria, would be compensated under the presumption of occurrence, the presumptive coverage. So basically, if a claimant fulfill the criteria that are on your screen, meaning presenting with a PTSD, post-traumatic stress disorder, diagnosed after or related to a claim after December 10, 2012, if the claimant is a firefighter, emergency medical technician, police officer, excluding RCMP, or peace officer, for instance, if they are with the condition, the date is good, the occupation is good, you fill the claim and the presumptive coverage would apply, which means that the disease is presumed to have risen out and occurred during the course of employment, unless the contrary is proven. So in this situation, it's best for the worker because if the employer usually disagree with this, they would have to bring elements saying, no, it's not at all related to the work. And when it's not under the presumptive coverage, it's totally different. You have to prove that your condition is related to work factors, which is a little bit more complicated or require a little bit of more documentation and investigation. So there are presumptive coverage applicable for PTSD, for several professions, usually first responders. Basically, we have to keep in mind one type of profession, and same for a traumatic psychological injury following exposure to a traumatic event. If the claimant, the worker, the patient you are seeing is diagnosed with PTSD or a depression that you feel is work-related, but the patient do not fulfill all of those criteria, please, if you feel it's work-related, do the reporting. It just means that it's not going to be the presumptive coverage. There's going to be an analysis. There's going to be an adjudication. They are going to look into details. It's not going to be automatically presumed to have risen out and occurred during the course of employment. It means that there is going to be the usual process for adjudication. So yeah, it's possible to have those diseases recognized as occupational diseases in Alberta. Number 4, is burnout a real diagnosis? I believe this one is my favorite. So you can't see how the line bars are moving, like it's quite exciting, like oh, it goes yes and then it goes no. It's really fascinating how it goes and the evolution of your answers. And again, thanks for playing the game and participating. It's really it makes the thing more interactive and more interesting to me. So I guess we're here. I'm going to share results. A difficult question. So 2/3 of no, 1/3 of yes. So yeah. So the answer to that is no. Burnout is not considered as a medical condition in the ICD-11. And I'm going to be like, honestly, from me to you, I don't like the concept of burnout. And I really think that we should get rid of this because it provides some fuzziness in the research, in publication, and it doesn't help patients at all. I'm going to give like a 5 minutes presentation on that. I could really expand and provide additional details, but I'm going to give you the key elements. So I would like to go back in the back 2 or 3 years ago. At the time, WHO was revising the ICD and released the ICD-11 that now is supposed to be the applicable version of the International Classification of Diseases. And at that time, WHO was releasing a couple of press releases to point out different points in the revision of the ICD. And one day, in May of 2019, they released a press release where they say that burnout was considered as a medical condition. And we were, all of the experts around the world, like shocked because it was brand new. And we were like, what are they doing? Like, what's the support for that? So they needed to publish a correction the day after that. And this is the correction that you have on your screen. And if you have good eyes, you can see that on the second line, 28th of May, 2019, you see it is not, and not is bolded because of the previous wrong report that was released by WHO. They made a mistake. So it created a lot of confusion because like there were some outlets about, oh, now burnout is a disease, it's going to change everything in terms of work-relatedness and adjudication and whatnot. And the day after, no, seriously, no. So burnout is not classified as a condition, but it appears in the ICD-11 in a category called occupational phenomenon. And it's defined here, and you have the definition in the red box. Burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. It's characterized by 3 dimensions: feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism related to one's job, reduced professional efficacy. And a syndrome, by definition, is no more or less than an association of symptoms. It doesn't speak to the pathophysiology or the logics of the connection of the different symptoms, just a bunch of symptoms tied together that we call a syndrome. And in here, those 3 bullet points really match the definition provided by Maslach with regards to burnout. The first point would match in the concept of emotional exhaustion, then depersonalization, and reduced personal accomplishment. So it really matches the 3 dimensions of the famous questionnaire, the most used questionnaire to assess burnout, which is the Maslach Burnout Inventory trademark. There are many issues with the questionnaire, the concept, and everything about burnout. And I tend to say that almost all of the bad practices in psychometrics are present with the MBI, basically. It is an inaccurate tool. There are internal validity issues. Internal validity is assessed by a dimension called the Cronbach's alpha. And as a rule of thumb, anything below 0.7, it goes from 0 to 1. Anything below 0.7 is considered to be unacceptable. And it's best if it's above 0.9. So it would be the best internal validity. So the English version of MBI, the MBI has two dimensions in the 0.7, 0.8 range and one in the 0.9. So not everything is great, but the 0.9, the best section of the MBI with the best internal validity, we need to look into it, because there are ways to artificially increase your internal validity by asking the same question several times. And this is what is done in terms of, it is a trick to increase your internal validity in the questionnaire. Good thing to have a validated questionnaire at the end of the day. If you ask the same question with a slight different wording, but at the end you are not assessing very different things, well, you're artificially increasing the internal validity. Second point with this is that you need to have a look of the internal validity in translated versions. And in the French version of the MBI, we are not meeting the 0.7 threshold in all of the dimensions. So it should not even be used in French. But believe me, there's a lot of published peer-reviewed publications that are including French version of the MBI. Because now the thing is that we rely more on the popularity of the MBI rather on the fact that it's a good psychometrical and evidence-based tool, which is not. It's used just because by habit. It's used because we have so many publications with this. It's the first thing you're going to pick if you're interested in work-related mental health. And people, basically, most of them are no occupational health experts, no work psychologists. They are not sure they would look into all of these details, use it and say, oh, here we go. There are no standard cutoff for interpretation, which provides with huge variation in burnout rates. And a couple of years ago, there was an interesting paper in JAMA where the authors were willing to do a systematic review and meta-analysis of the burnout rates in physicians. It ranges from 0 to 82.5% because of inaccuracies in definition. And one of the arguments that persists a little bit with burnout is we need to keep burnout as a concept because it's related to work. It speaks to the work-relatedness. This is incorrect. This is false. Burnout does not correlate better than depression with work-related outcomes, which means that when you do the testing, because all of this is based on peer-reviewed evidence like literature, psychometrical studies, where all of this is analyzed into details, depression can be work-related and maybe better tied to work outcomes than burnout is. So it's not even true that burnout is this condition so related to work. And the thing is that for your patients, if you diagnose them with burnout, most workers' compensation boards are likely to either requalify burnout into another disease or dismiss the case. So take-home message with regards to burnout. If you think that someone has burnout, I think that this should be considered as a complaint, a patient using their words to express something that is just, I'm not feeling well from a mental health perspective, and I think this is because of my work. And as a professional, you need to do an analysis. You need to take, not to take this as a diagnosis offered as a gift, like, oh, I suffer from burnout, yes, diagnosis is burnout. No, you need to do some work, some analysis, to use your expertise, to look into detail and see whether or not another condition that is recognized would match. And it's very likely that there is, because from a psychometrical standpoint, in most cases, it would match better the definition of depression that can be work-related and reported to WCB. So you would do an assessment with, as you would do with any other patient reporting a mental health issue. You would look into symptoms, weight loss, sleep disorders, appetite, and things like this. Second, with burnout, it is not normal. It is not physiologic. It is not temporary. This is my huge concern with burnout. As we keep the wording burnout, we are having in mind something that is quite normal. It goes with the risks of working as a healthcare worker, a physician, or some demanding profession. But if we were to use the wording depression, we would change our minds and we would think that, hey, the risk of depression is to commit suicide. So we would assess the suicidal risk, which is my third point in here. It's important when you think about burnout to go all the way to assessing the suicidal risk, because this is ultimately the very huge risk with a worker, with a claimant, with the patient that presents with this kind of symptoms. And at the workplace, if you have a colleague, this is point number 4 in the slide, my recommendation is not to act as a therapist. You are not your colleague therapist. You have to set boundaries with that. You may be in power differential relationship where you may feel that it's good to discuss about that with your colleague, but you're the supervisor. And the colleague is not really in a position to say, yes, I'm happy with that. No, I'm not happy with that. So be mindful of that. Focus the discussion on the work outcomes. The work is done, the work is of quality, the tasks that are assigned are completed. And when it reaches mental health, you need to refer to external providers. Keep in mind that workers with mental health conditions that are disclosed at the workplace are being discriminated. They have reduced access to promotion, they have less opportunities to get a paid increase. So as long that they would experience discrimination that is documented, I would be mindful of not spreading the word and protect the workers and having them benefiting from support and care outside of the workplace, because workplace is not a therapy center. And the last one, in a couple of minutes, is it mindful to use mindfulness at the workplace? And here you have a range of different options, all the way from, yes, no matter what, it's always beneficial, and no, it's never beneficial. And in the middle, you have maybe, but at some conditions. I'm not sure there would be a right answer to this one. I will give my opinion. And what I would like to point out is, in this presentation, I'm not willing you to just believe my opinion or take my word for granted. This presentation is really intended to be a little bit of a mind checker, like for you to have a different perspective on things that are always presented with the same perspective. I really want you to think differently. Maybe you wouldn't change your mind, and that's very fine. But really the idea is to present you with a different perspective. Oh, so no one is thinking that no, it's never beneficial, and only 6%, 2% said yes, it may be beneficial after the working conditions have been improved. I would have answered personally either no, it's never beneficial, or yes, but after the working conditions have been improved. So I wouldn't be the majority. In a couple of minutes, I'm going to give you some key points about this. We can't possibly go into details. Basically, it's the purpose of the research we are currently undertaking with the funding of WCB that I talked in my disclosure earlier in this presentation. Just as a reminder, mindfulness belongs to the class of positive psychology methods. It's a form of awareness that stems from attending to the present moment in a non-judgmental and accepting manner. So it's a state of mind. And to reach this state of mind, you have methods such as MSPR and BCT or many others that help you reach this state of mind. In a nutshell, literature with regards to mindfulness has many flaws when you start to look into details with regards to workplace settings or work-related outcomes, problems with study design, problems with the assessment of outcomes, and a phenomenon that has been specifically described with regards to mindfulness, but it can be used in other settings. But the first description that I've seen was really tied to mindfulness, was researcher allegiance. Researcher allegiance is the researcher's belief in the superiority of the treatment and the superior validity of the theory of change that is associated with the treatment. And it occurs when the researcher is also a practitioner, that is also providing some therapy sessions on the method they are studying, which is basically a conflict of interest. And we usually think about conflicts of interest with the pharmaceutical industry. But if you are publishing on the method and you're doing your business based on that method, it should be also considered as a conflict of interest. And a lot of research has this flow because people are interested in doing research on what they are practicing as well. So it's a complicated question. But from the occupational health perspective, we do have some frameworks, we do have some text, and not everything is the same. And especially, and it's in red in your screen, adaptation of work to the worker is not equivalent to adaptation of worker to the work. And when you ask people to do mindfulness, somewhere you're asking them to adjust to working conditions that are not even the scope of the mindfulness workshop. So it is not the same, like it's not kind of an equal relation. You have to think about changing the work condition or asking the worker to cope with working condition, which is not the same. And in our important texts and code of ethics, for instance, the ICO Code of Ethics, International Commission of Occupational Health, it says that we have to promote the adaptation of work to the capabilities of workers. And in the European Union context, in this legal text of 1989, it is said in the general principles of prevention that we have to adapt the work to the individual. And I would like to finish with this slide. You may have seen this slide. You may have seen this triangle with the spike down, the hierarchy of control. This is the CDC NIOSH framework of the hierarchy of control. And people may miss that in the expression hierarchy of controls, the first word is hierarchy, which means that not everything is equivalent. There are things that go first in the strategy of prevention and things that go last in the strategy of prevention. And this is the big discussion that I usually have with stakeholders and companies or colleagues even involved in this. Well, we can do mindfulness and we can do other things. This is now how prevention is envisioned by NIOSH. No, you need to have a plan and strategy. What goes first, what goes second, what goes third. Elimination, substitution, controls that are engineering, administrative, and PPE. It's valid for physical hazards, chemical hazards, biological hazards, COVID at the workplace, and it's no different with work-related mental health. It's the same. You would need to consider the collective protection before the individual protection. And at the very best, providing mindfulness tip would be no more than providing individual focused tips that are not related to workplace factors. So before doing this, you need to consider what can I do at a collective level? Elimination, substitution, engineering controls. Well, some part of your work-related mental burden pertains to equipment that is not working properly. So maybe having a look into it. Administrative control, proper staffing, proper training, proper support. All of this needs to be considered first before coming to the individual bits. So this is basically what I had to say to you with regards to those questions. Here are the learning objectives that I hope that we've kind of reached to help you think about reporting to workers' comp and to have a critical thinking about mindfulness and positive psychology method, along with so many things that we've reviewed. So I'm going to finish my presentation now, and I will hand over to Dr. Campbell for the Q&A, and if you have some, and I'm happy to take those questions.
Thank you so much. That was so interesting. And I'm just, while we're putting questions in the Q&A box, please, we're going to put up a little poll because Quentin has prepared a much more intensive course. And we're just really curious to know if this is something that would be of interest to anybody. So if you don't mind, just while you're thinking of your questions and typing them in the Q&A box, if you could just give some feedback to Quentin about what might be interesting. And Gisela, I see that you have a raised hand. If you don't mind just popping your question in the Q&A box, that would be great. I'm mindful of time. I know this has been so interesting and we're almost to the hour. Quentin, are you available if we were to stay for an extra, 15 minutes?
Yeah.
People who might be able to stay and appreciate that everybody might have to go back to clinical duties, but yes, Rachel, the recording will be available. It will be emailed next week to everybody who registered for the talk. So thank you for that. As we always do at the Office of Lifelong Learning, we will always do that. Okay, and perfect. So it looks like you're getting some really helpful information there, Quentin. And yeah, so Quentin has been very passionate on this for some time, and so it would be very interesting, I think, to hear more about it over a longer course. So Gazella has a comment she'd like to make on the mindfulness part. Let me see here. Now, Jessica, how do I make it that Gazella can speak? I don't know. We've always done this by typing. Well, Jessica's figuring that out. There's also a question here from one of the colleagues. Could you speak a bit, Quentin, to the interpersonal factors of supervisors that affect mental health of workers?
Oh, that's a great question. So yeah, I tend to see interpersonal relations at the workplace as being mediated by the working conditions. So meaning that we may be with people that we don't get along with, people that we are not happy to be with. But this is the nature of work. We are not recruited because we like each other. We are recruited because we are professional, here to fulfill some tasks, here to fulfill some duties. And we're not supposed to be recruited because we are happy to be with whoever. And colleagues may change over the time as well. We may get along with someone and this person is replaced, moves to another position, and it's someone we might like better. So the thing is that really a good organization, as I usually say, is an organization that is able to make people that don't get along together being able to work together. So when there are interpersonal problems, like there are conflicts at the workplace between two persons, my take as an occupational medicine expert and an occupational health expert is to maybe see in the working conditions what may trigger this, because sometimes people do not really get the overall picture of how the workplace is organized, what kind of problems. Maybe it's because they don't have the tools. I had an example in my mind of a colleague discussing with me that she didn't get along with another colleague, and I was questioning her, but do you know if this person has been providing training? Not so much training. Do you know if she's sure about what you expect from them? What are the objectives that are assigned to them? And when you go into specifics, you can clearly say, hey, there's kind of a pattern, not a lot of support, not a lot of training, not a lot of things that are normally offered by the organization. And all of this is seen in the quality of the interpersonal relationship that degrades, goes down. And at the end of it, we can say, oh, we need to do a new training session on respecting colleagues and how to say hi to colleagues. But the working conditions do not change. The person leaves their position because it's no longer working and is replaced by another one. And nothing changes because we've not been questioning the support, the training, the tools, and all of this that at some point will have an impact on the quality of the interpersonal relation. So I'm not saying that all of the conflicts at the workplace are always related to problems in the work organization, but I think that it's worth having a look into it.
Thank you, Quentin. Gazelle, I think we've now figured out how to get you to be able to speak. So if you want to unmute and contribute, please, yeah.
Thank you so much. Thank you for this really interesting presentation today. I just wanted to speak to the mindfulness part a little bit as someone who does practice and teach mindfulness. I think I look at it in a different way than how it was presented. To me, or like the way I've learned it, and I mean, there is evidence to what I'm sharing. I'll refer you to the Mindful Practice Group in Rochester, who have evidence-based programs. They've published a lot about this and how it pertains to physician burnout and empathy and things like that. But like mindfulness is not really to make people get used to their toxic work environments. And it isn't, from my perspective, just an individual tool either. Like there's just so much more to mindfulness. It is, as you mentioned, it is a sort of a way of being, not just a mindset, but a way of being. And it involves, it's so much more than meditation. It involves self-reflection, looking at biases, our own conditioning, and so many other things that I feel like if leaders, for example, or people who are in charge of those systemic areas that require change, if they had that perspective and that mindful lens to look through, that a lot could really shift. So
Gisela, I'm gonna wind you up here. Thank you. I think you've
okay,
sort
thanks.
of made your point. So let's give Quentin a moment to sort of reflect on that. But thanks for that.
Yeah, no. Thank you for sharing your view on this, and I understand that you are practicing as well on this field. So you have also your experience that is also a different experience than the one I may have. So yeah, I guess everyone may keep a different view on this topic about the use of and the relevance of using mindfulness in the workplaces. My point was really to bring the occupational ethical framework into it and the hierarchy of control, because I do feel that it's not so, like to be clear, occupational health is not the main priority in training in academic field, and I do feel that some people are lacking knowledge about it, like the hierarchy of control, ethical frameworks, and things like this, like the fact that you are to use individual focused methods after looking into improvement of the working conditions and things like this. People just sometimes don't know about it. They go straight forward, like mindfulness is good, and we go for it. And usually companies do like this because it's a way to, for some, I'm not saying that it's your experience, but in my experience, I've seen companies using this as a way to avoid looking into improving the working conditions, which can be a danger. Like you're using mindfulness because you're asking the workers to go into individual training to basically help them cope with working conditions that are not changed. I'm not saying that it's always the case, and I can totally envision that there are programs where there is a mindfulness component to a bigger review of the working conditions. It's not always the case. And the thing is that if you do polls, satisfaction is good. Workers do like this because they are outside of their working conditions that are so bad. So having 2-hour workshops where they are provided with nice and professional training in mindfulness may be cool. So you may have immediate feedback that is interesting and support that. But really my point is to have this bigger thing and the hierarchy of control and all of our ethical framework. I acknowledge that it's quite short and would require additional, discussion. And also I acknowledge that not everyone may agree at the end of the day on that.
No, but I think, thanks so much. It was a very interesting sort of segue, and thanks, Gisela, for bringing it forward, because, I think we're talking about a little bit of different things, right? And I think really what your main message I'm carrying, Quentin, is that we really can't ignore some of those structural issues that make it hard for people to do their work. And so like a more rounded approach. We did have a quick follow-up as well from the colleague who asked before, and you had mentioned proper support. And this person was just sharing, could you elaborate on that? They're not feeling particularly well supported. They're being asked what, maybe by leadership, what they need. What resources exist for a person who might find themselves in that situation? Is there any guidance or recommendations or places that people could seek assistance?
Yeah, so thank you for this question. It would really depend on the workplace where you are. There are workplaces, and usually the big workplace, where there are organized employee assistance programs, for instance, where workers can find some support with regards to mental health. It's really important to have, to make sure that those providers are professional and with respect confidentiality before jumping into it. So this, in big companies, usually there is an access to this. Then maybe for smaller businesses, it may be more challenging because there is no mandatory occupational health services to be provided for all of the workers. That is totally different from France, for instance. So for people in these situations, they may discuss with their family doc or counselor to see whether they can have access to an occupational health specialist to look into it. And also in workplaces, on the working condition piece, support is also not about just providing mental health support and health support. It's also about providing support to do the job. So in this situation, it also depends on the workplace, and if you can find someone able to hear from you and your concerns. It would really depend on the workplace where you are, but the support should be envisioned from both a health perspective and also the fact that you're provided with the tools, the training, the resources that you need to do your job. It would depend on the company.
Yeah, thank you so much, Quentin. And as a family doctor, I'm excited for the shout out to the family doctor. Sometimes we can be helpful. So Maggie has a question, and I think just to expand on Maggie's perspective here in the chat, you were doing also research on COVID, Quentin. And so she's saying that, this is a very, very trying time for many, many reasons for people. And people are feeling very overloaded, having a lot more job-related burdens. Right now, a lot of people are out. I know in the hospital setting, over the holidays, some of our residents were doing way too much call because it was this one, that one, this one, that one, getting COVID. So do you have some thoughts for these issues, for these kinds of situations that people are finding themselves? How do people stay safe, and how do people navigate that?
It's a tricky question because, it gets political at some point, because when it's about the work, like if we take the situation of COVID, it depends on things that are decided at a governmental level in terms of putting or not restriction, having proper support for the healthcare worker, providing funding to have some staffing. So all of this is at a political level, which is tight, and sometimes it may be controllable to find ways to deal with this without getting political. But no matter what, these decisions have an impact on the health of healthcare workers. For instance, people having to work in COVID wards and being asked to do additional hours, they may reach the threshold of 55 hours per week. They are going to have an increased risk of myocardial infarction and stroke. This is an occupational risk that I'm a little bit concerned with. And the thing is that if the only response is like, hang on, it's going to be better, there's light at the end of the tunnel, and wait a little bit, well, it may well continue to exhaust healthcare worker. Retention of older healthcare worker may decrease. People may consider retirement early on. At that point, it gets political. I guess that organization can do things to a certain extent to support their workers. They can adjust things, but at some point they may lack a little bit of operational leeway to adjust that.
Yeah, no, thanks for that. It's a very, very good question. Very hard one. Absolutely. I had one question for you too, if I could pop that in there, just on the Depression Association study. There's been a lot of question out there in the literature about the definitions around depression. Mm-hmm. And there was a very nice book that was written called Reinventing Depression, A History of the Treatment of Depression. This was in primary care from 1940 to 2004. And the thing that we see across the spectrum of practice in primary care is something which I almost call dis-ease, all the way through to psychiatry of full-fledged disease. So if you use certain criteria for depression that would be more common in a psychiatry office, they miss a lot of depression that's seen in primary care. And it creates a problem of classification. And interestingly too, if you look at different taxonomies for how we classify, not everybody uses ICD-11. It's particularly ill-suited ICD-11 for primary care. So we see these, if you look at Snowbend or other taxonomies, you'll see that physical emotional exhaustion as a code. So I guess my question is, when you look at your systematic review and those associations, given the challenges that exist in the literature around the definition, and also the cultural acceptability of the diagnosis, I guess I'm just curious where you think the literature is going in that space, because it's perhaps not capturing what's reality on the ground.
That's a great point. So with regards to those systematic reviews, we are with ILO, we are with WHO, we are with huge stakeholders, and they were super concerned about credibility of the work. So they set up the threshold quite high in terms of accuracy of the diagnosis, and they got rid about, like for instance, burnout was not even considered, to look at too fuzzy, too problematic. So they really kept just depression and matching. I can't recall if we had both the DSM-5 and the ICD criteria, but really we needed to demonstrate that in the studies, criteria for the diagnosis were super clear. So all of the cases you are reporting, those like in between, not matching the criteria, but not really well, those you may see in family practice, may not be captured in the systematic review. This being said, there are so many reasons why this relationship couldn't be really well established, because we need to get into the specifics of each one of the patients, why they are not getting well. And it gets difficult to have the big picture from an epidemiological standpoint. I'm not sure that enlarging the criteria and including the patients you are referring to would significantly change the results. It may, I'm not sure about it, but really for this review, the criteria were pretty much strict. Like, you were working with WHO. I don't know if any of you have already been working with WHO. They are super strict with the framework, from conflicts of interest to the writing and how it's been published. We were aiming to do it in less than 1 year, and it took 5 years to do all of this. So yeah, you can see that there's a lot of complexity that's been added to the framework.
Well, I'm mindful of time. I'm going to give Manu the last question here. And she put it in the chat, but it's by mistake. But her question is, what are your thoughts on the shift to reframing the discussion from that of burnout to professional fulfillment, particularly with regards to healthcare professionals, including physicians?
And that's a good question from Manu, and thanks for participating. That's not a bad idea, but it needs to be reframed, I think, in terms of relation with work and not just being happy. Like, it may be tricky to really make sure that we are not talking about happiness in general, but really, as you mentioned in your question, professional fulfillment. So I guess this would be something that would be to discuss in evaluation interviews that we have every year. And this should be, the workers should be given opportunities to discuss this notion of professional fulfillment. Are they given opportunities for promotion, for additional training? Are they feeling well in their position? What are their expectations? Where do you see yourself in 5 or 10 years from now? All of this should be assessed in those annual reviews, and all workers should benefit from that to a certain extent. And then there must be plans to achieve those goals. This is a conversation that would be a better fit rather than talking about burnout in general. I agree with that.
Mm-hmm. Good. Well, I think that's a really interesting place to end on, and really appreciate the remarks, and really appreciate all the engagement and participation with everybody. And Tanya, thanks too for your note that you put in, and we'll reflect on that. So yeah, let's go back and get everybody back to work. But thank you, Quentin. It's been really helpful and wonderful to learn from you. And you're getting lots of nice comments in the chat. So it's a good job.
Thank you very much for organizing, and thanks to all participants for their participation and interest. And have a nice day.